Viewing the PEPR report under home health PDGM webinar. Thank you for participating in today's webinar. I am Hannah Vale. I'm the Vice President of Growth and Retention at HealthRev Partners. HealthRev Partners is proud to sponsor this webinar, and we are a tech-driven consultative revenue cycle management company. We deliver tailor-made solutions designed to advance your agency and provide exceptional care by accelerating cash flow, sparking continuous growth and reinvestment, and providing peace of mind. I will start off with some housekeeping items. You can find the handout for the presentation on this link in the chat. So if you click on the little chat button, I will make sure that it is reposted just in case you are just now joining to everyone in the meeting. You can download the handout there. If you have questions throughout the webinar, you can message me in the chat, or you're welcome to ask them to everyone, and we will get to those at the end, time permitting. We value your feedback, and we do have a short survey at the end of the webinar that we're asking each of you to fill out. 3 survey participants will be selected to receive an Apple AirTag just for filling it out. We also want you to go ahead and mark your calendars for some of our other upcoming informative webinars. On October 21st, we have a webinar scheduled on PPS. November or December, when the final rule comes out, we will send out an invite for the final rule. January 20th and February 17th, we will be pairing a webinar on cost reporting. So there will be a part 1 and part 2 on that in January and February. I would now like to introduce you to our speaker today. John Reisinger is a CPA. He's the principal of Innovative Financial Solutions. He has over 28 years of experience in the home health industry. His diverse experience includes Medicare auditor, a home health financial executive, and for the last 13 years as a highly in-demand financial and operational consultant for home health and hospice, and as a turnaround specialist. For the last 20 plus years, John has also been an industry leader in educating the industry about the proposed rules published by CMS and then how to participate in other rulemaking processes. John, I'm going to go ahead and turn this over to you.
Okay. I appreciate that, Hannah.
Mm-hmm.
And I'm assuming everybody can see my screen now. Hannah, you can see it?
Yes, I can.
Okay, great. Hello, everybody, and thank you for joining us today. Today, I'm going to be talking about the PEPR report, which PEPR is an acronym for Program for Evaluating Payment Patterns Electronic Report. So sometimes I'm going to say PEPR report, and it's a bit redundant because the last R really means report. But I want to go through this report because, one, I have found that there's still a significant portion of the industry, the home health industry, that doesn't even know that this is a report that's available to them. And also that there's a significant number of those that do know about the report, but have trouble reading the report, understanding what the report's trying to do, so that it limits how valuable the report is to the agency. So what I want to try and do is try and look behind the curtain and try to explain the different aspects of what the report is trying to do. So this latest release was available since July, and it is through the calendar year 2020. So it has been modified for PDGM. Okay, so CMS's responsibilities are many. So not only do they administer the Medicare program nationally, but they are also entrusted to protect the program from waste, fraud, and abuse. Many of those ways are subcontracted out by CMS, such as their work with MACs, RACs, UPICs. I'm sure, I assume everybody is familiar with these to some degree. The PEPR is created by a group called TMF Health Quality Institute that CMS contracted with back in the early 2000s to develop this type of report for all different segments of Medicare. And the first one they came out with was for short-term acute care hospitals back in 2002. The first home health specific peppers were available back in 2015. So it's a relatively new report for those of us in the home health. So the pepper report is a report that's updated annually. So again, as I noted, it's been available since July 9th. And the pepper is considered an educational tool to assist providers in assessing their risk of generating and or receiving improper Medicare payments. It's trying to put a tool in your hands to help you identify potential issues before they might be identified by the MAC, RAC, UPICs, etc. The pepper identifies what they call target areas that tend to indicate the potential of an agency receiving improper Medicare payments. On the report, there's a 3-year rolling comparison. So currently it's going to be 2018, 2019, and 2020. So something to keep in mind is 2018 and 19 are pre-PDGM. Therefore, some of the target areas are going to be blank for 2018 and 2019, since some of these target areas are specifically designed for the changes to PDGM. So the pepper presents the information in both percentages, and percentiles. Okay, and this is where it gets a little confusing sometimes. Percent is a concept most everybody is familiar with, where it represents X out of 100. A percentile is where the issue starts to come into play because it's not as commonly understood as percentages. So I went back to sort of help explain this to the Merriam-Webster definition. So their definition is a percentile is a value on a scale of 100 that indicates the percent of distribution that is equal to or below it. Therefore, I have X here, but you can put in any value. In the report, we're going to see 80 is the value that they use. So I'll just substitute 80 for X. Okay. Therefore, the 80th percentile means that 80% of the items measured were less than or equal to the value identified at the 80th percentile. Or in other words, being at the 80th percentile means that only 20% of the measured items were greater. So the key difference between percentage and percentile is that a percentage is a mathematical value presented out of 100, and a percentile is the percent of values equal to or below a specific value. So the percentage is a means of comparing quantities, whereas the percentile is used to display position or rank in a hierarchy scale. So percent just means 100, so 80% would equal 80 out of 100, 40 out of 50, 20 out of 25, and so on. Percentile, again, is a ranking of order. So being at the 80th percentile would mean that the target measured is greater than or equal to 80% of the population items measured, or it's in the top 20% of the population of items being measured. And in the Pepper report, it's because it's in the top 20% that they're calling this an outlier, meaning that it's potentially indicative of an issue, something that the agencies should be looking at. So, and that's what I just said right here. Okay, so, and that means that there is a higher risk for causing the agency to receive improper Medicare payments. So we'll look at the target areas momentarily when we take a look at the report itself. But first, I want to help give a big picture overview of the Pepper report. And portion of this report is going to be talking about what the agency is, what the agency scores were, but it's also going to be comparing those scores to 3 groupings. And that's what I want to talk about now, the logic behind the groupings. okay? Because the first grouping is national, and that's pretty basic because that's going to be all home health agencies in the Medicare program. The second, which is going to be fairly straightforward too, is going to be state. So you're just going to be comparing with other agencies within your state. The one that gets a little tricky is jurisdiction, okay, because it's dependent on your map. Okay, so the jurisdiction includes all home health agencies within that max coverage area. So you might be an agency out in California. So you're part of the NGS is your MAC, and you're in jurisdiction 6. So you're going to be the darker green color states that are highlighted there. So it's going to be the West Coast states coming in as far as, Idaho, Nevada, Arizona, but it's also going to include the upper Midwest with Minnesota, Wisconsin, and Michigan, but it's also going to include New York, New Jersey, and down below at the bottom right, Puerto Rico. So it's not necessarily contiguous, so it gets a little confusing here. And one of the things I pointed out here, and I'm going to point it out again, is that so far, only 37% of the home health agencies have actually downloaded their 2020 PEPR report. So again, the PEPR was created to help agencies identify potential areas of vulnerability for improper payments. Okay, so you can be reactive to try to address this issue. Now, there is no requirement to download, to use, or to take any actions based on your PEPR statistics. Okay, but it is free. It is a free, easily accessible resource to view your statistics and the programs, meaning the other groupings, for various target areas included in the report. And considering that CMS is coming back out with their TPE, their targeted probe and educate audits fairly soon, I would think this would be something that everybody ought to be wanting to do. But currently, only 37% of the agencies, again, have downloaded this. And to me, this is a missed opportunity. The PEPR report is an Excel file that can be downloaded by any and all home health agencies. Okay, they're generally available for 2 years after their release. And following is the link to download your PEPR report. So this is the PEPR homepage. So this is where you would go to find out anything about the PEPR. And it's only available to your agency per se. Okay, it's not available to the general public. It's not available to consultants. So if you have a consultant that you want to work with, clients of mine that want me to review and summarize what their PEPR is saying, the client, the home health agency has to download a report, and then you share it with whoever it is that you're outsourcing to help review the report for you if you don't do that yourself. Or any other unauthorized recipients. PEPRs are not sent to the RACs or MACs. And when you're thinking of the TPE audits that are coming up, you think, okay, that's a good thing. But a database that has all this information in it for all agencies in their jurisdiction is shared with the MACs and RACs. So even though they don't get your particular PEPR report, they're provided a database that has all this information in it. So they can identify this for all the home health agencies in their jurisdiction. This is the user's guide. Okay, so that's the 6th edition that you would want to look at for home health agencies, because each segment of Medicare, hospitals, hospice, etc., has their own user guide because it's specific to them. Okay, and here is the URL to find that. But the big thing is you just need that first part of the URL to actually get this. Where it's HTTPS all the way up through cvrpepr.org. As long as you have that, you can get the PEPR report, you can get the user guide, you can get everything. Now, the home health specific PEPR is made up of 13 schedules. And remember, it's an Excel file. So that means this Excel file for your agency is going to have 13 worksheets or 13 tabs in this Excel file. Each one of these tabs is going to be a schedule. The first 3 of the report are introductory, okay, with the first two being purpose, where it just gives you a brief overview of the premise of the pepper to try to give you some insights into what the concept is behind it. The second being definitions, and this is identifying the calculations for the 8 target areas. So it's going to be identifying what's going in the numerator and what's going into the denominator for each one of these 8 target areas that we'll look at shortly. This third slide is titled Compare, and this is like an executive summary of the 8 target areas results. Okay, so we're going to take a look at this on the next 2 slides. Okay, so following is a snippet of the compare slide for the pepper report for the sample agency for 2020. Okay, so what I want to point out is I'm saying I want you to look on the left-hand side at the bottom where it says target. Those are the 8 target areas. So when we get into the report, each one of those target areas is going to be a worksheet unto itself. So there's going to be additional detail in each one of those. Then we want to look at columns 3 through 6. Okay, because column 3, the percent rate, that's the score of this home health agency. Then columns 4, 5, and 6 are where that home health agency ranks as far as the percentile in each one of the jurisdictions. Okay, so this is just a bigger presentation to make it a little bit easier to see. So when we look at the third column where it's percent or rate, okay, we can see 3 items, 3 values that are of a red font. Low comorbidity, the third one, average case mix weight, and the 8th one, admission source 46.3. Those 3 are red. When we look to the column immediately to the right, this is where they rank in the national percentile. And remember, anything that's at or above the national 80th percentile is going to be deemed an outlier for the pepper report. So in each one of those, when we look at the national ranking for the agency, low comorbidity, they're at the 87th percentile nationally. For average case mix weight, they're at the almost the 94th percentile. And admission source, they're at the 91st percentile. All of those are above 80. That's why the fonts are red. So those are indicative of areas that you would want to look at. So the next 8 schedules that we'll take a look at shortly are the target areas. And then there's going to be 2 more schedules after that, 2 more worksheets after that we'll look at the end. The first one is top clinical groups. And this is going to be the agency's list of clinical group periods of care that begin in the most recent calendar year. So it's going to be for 2020. And when I say clinical groups, remember, this is those 12 clinical groupings that have come about because of PDGM. And then the last worksheet is going to be the jurisdiction top clinical groups. So it's going to be the same thing, but it's going to be the same thing presented with all home health agencies in that jurisdiction. So again, the focus points on this report are what are called target areas. These are the areas as identified as having a high risk potential for improper Medicare payments. That is, billing and or coding issues, errors, the provision of unnecessary services, etc. And oh, by the way, these are the exact things that they look for when CMS is doing the TPE audits. Okay, so they're giving us a tool to help try to identify that ahead of time, to try and address it ahead of time, or to look at those areas. It doesn't mean that there is a problem there. It's just there's a higher potential for a problem there. So if we have answers to their questions when they are doing their TPE audits ahead of time, then that's going to give us a leg up on trying to deal with what we have to deal with the TPE audits. So a target area is calculated in the form of a ratio, with the numerator representing the count of items in question that are at or above the target of what we're looking at, and the denominator representing the population of all items applicable to what we're looking at. And again, that's identified on the second tab of the worksheet, of the spreadsheet. okay, under definitions. It's going to show what the 8 target areas are, and it's going to show what's in the numerator and what's in the denominator of each one of those 8 target areas. So following, I'm going to present a snippet of each of the 8 pepper target areas from a sample pepper report. The report may or may not show values for 2018 and 2019, but will always show values for 2020. And that's because 2018 and 2019 are pre-PDGM, and several of these target areas are PDGM specific. So the top portion of your report is going to be titled Your Home Health Agency. And you'll see when we look at it, I've actually highlighted it. I didn't highlight it on the handouts, but because when you download your report, it's not going to be highlighted for you. But I highlighted it on this presentation to make it stand out. So the information that's at the top of the report of each one of these schedules is going to be germane to your home health agency. Underneath the bottom portion of the page, it's going to be titled comparative data, and that's going to be the data at state, jurisdiction, and national results at the 80th percentile and sometimes the 20th percentile. So when your agency's rate is greater than or equal to the 80th percentile nationally, it is deemed something that you really should review for appropriateness to make sure that there are no issues of receiving improper reimbursement. Again, for home health under PDGM, there currently are 8 target areas, The first one is low comorbidity. Note the red asterisk there. The red asterisk means it's new for 2020 because it's applicable to PDGM. And this has to do with the 4th character of the HIPS code. Remember, the HIPS code is a 5-character code. The 4th character of the code equals a 2, meaning that one of the secondary diagnoses that we are submitting, that we are including in the claim, is bringing in additional revenue over and above what the base 30-day payment for this patient encounter would have brought in. Second target area is high comorbidity. 4th character of the HIPS code equals 3, meaning that 2 or more of the secondary diagnoses are each bringing in additional revenue to this 30-day payment period. Third target area, average number of periods. This is similar to length of stay or similar to number of 30-day payment periods per unduplicated census for the calendar year. Number 4, it's identified as average case mix. I put weight under behind that in parentheses because really just about anything we see from CMS, they're calling it average case mix weight. Okay, so average case mix weight, same thing. Okay, and this is the average case mix weight of all payment periods during the calendar year. 5, periods with low visits. This is the percent of 30-day payment periods that you are either at LUPA threshold or you have one additional visit. So you're just getting over that LUPA threshold. You're just doing enough visits to get the full episodic or the full 30-day payment. Number 6 target area is the non-LUPA payments. This is the percent of periods not receiving a LUPA payment. Conversely, something to keep in mind with this is that if this is the percent of periods not receiving a LUPA payment, the inverse of this is going to be the percent of periods that you do receive a LUPA payment. Number 7 target area, outlier payment. This is the outlier payments as a percent of total Medicare payments. I'm going to talk like this, just like I'm going to talk about all the other ones. Okay, but I'm going to add a little something to this because this is something I've been talking about for years and years and years, going back to the early days of PPS. Because what I have found in my presentations, my talks, when I'm working with clients across the country, either on site or remotely, is that the vast majority of the industry really doesn't understand how the outlier provision impacts them from a cash flow and from a bottom line perspective. So I want to try and give you a little bit more insights so that you understand that, so you can get a better feel of how beneficial is the outlier provision to our agency, to my agency. And the last target area is admission source. And this is the percent of periods with institutional as the admission source. So let's get right into it. This first one we're looking at is target area 1, low comorbidity. So you can see that I've highlighted in sort of a tan at the top of the page, your home health agency, and that's just the information for the home health agency. And below we have comparative data, and that's for the national jurisdiction and state information. So low comorbidity, we're just looking at this for 2020. So here we see that this agency has 44.4% of its 30-day periods having a low comorbidity revenue adjustment, a revenue increase. Okay, now it is a red font because compared to the 80th percentile nationally, it's greater because the 80th percentile nationally is 42.3. Okay, so then that's why it's high. It has a red font because they're trying to make it stand out, saying this is an area that you may want to take a look at. And then the bottom of the page for each one of these 8 target areas has this graphical presentation. So this is at the bottom half of each of these 8 target areas. Okay, it shows the agency results as a blue bar that we see over at the right, and the other comparative metrics as the various lines, dots, dashes, etc., that you can see in that legend right there. Okay, the takeaway here is to note that the agency's results, the blue bar, exceed all the other comparative metrics, particularly the national 80th percentile. Okay, this means that there's a higher concern of overcoding of secondary diagnoses with this agency, with this situation. Okay, we look over at suggested interventions to the right, and we have, in this situation, it doesn't happen all the time, but in this situation, we have the suggested interventions went above the 80th percentile, and underneath that, went below the 20th percentile. We're above the 80th percentile, so it says there's, this could indicate a risk of potential overcoding of secondary diagnoses. A review of the medical records may be considered to determine if the coding of the diagnoses were substantiated by the medical record. So again, this ties right back to the TPE audits. They're going to be coming back into play soon. So this can really be beneficial to help you prepare for that. It doesn't mean that you are doing something, that the agency is doing something wrong. It just means that there is a higher potential for something wrong being done here. Now, all the target areas have this graph, as I noted, but I'm only going to be showing the first 2, this one and the second target area for time, due to time constraints. Okay, so this is target area number 2. So this agency has 18% of its 30-day payment periods for 2020 as having a high comorbidity adjustment compared to the 80th percentile nationally at 18.7%. Since the agency's rate is less than the 80th percentile nationally, this is not considered an area of concern for this home health agency. And again, here's the second page with that graphical presentation. The blue bar is the agency, and we can see that several of the metrics are greater than the blue bar of the agency. In particular, the solid red line, which represents the 80th percentile nationally. Okay, so the takeaway here is that the agency's results are less than the national 80th percentile. So there's a low concern of overcoding of the secondary diagnoses, at least as far as when you have multiple secondary diagnoses. Note the suggested interventions. They give you some insight into what you may look at, how you should look at it if you are considered an outlier. So again, this is going to be the last graph presented. From here on out, I'm just going to be looking at the top portion of the pages. Third target area, the average case mix weight. This agency's average case mix weight of 1.24 exceeds the national 80th percentile rate of 1.18. Okay, therefore the 1.24 is a red font, okay, to indicate that there is some potential risk of overcoding the clinical, functional, and/or comorbidity status of the beneficiaries treated. And this is a pretty big issue because this ties to an adjustment that under PPS from 2008 to 2019, they didn't use it every year, but they used it most years. CMS had come up with an adjustment that they called the nominal change in the case mix weight adjustment that they used to cut home health reimbursement by over 20% during that 12-year span of time. And that basically was with what they said was the increase in the case mix weight that had nothing to do with an increase in the patient's acuity level. In other words, it was the agencies in the industry gaming the system to increase reimbursement that had nothing to do with the patient's condition. And I bring that up because in the 2022 proposed rule, CMS did note that they're going to almost definitely going to be reinstituting that or a similar called adjustment in the future, because they said that the national standardized 30-day payment rate that they came up with for 2020 was already 6% too high. So, but they didn't want to make the adjustment this year being still under COVID. So, but it's something to keep an eye out, open and, out for in the future. Target area number 4, average number of periods. Again, similar to average length of stay, something like that. This agency has 1.87, which is far less than the national 80th percentile rate of 4.4. So it's having 1.87 30-day payment periods per unduplicated census as compared to the national average, which is 4.4. Therefore, the PEPA reports indicating that there's low concern of the agency maintaining patients on the rolls after there's a need for skilled services. Okay. One thing I wanted to point out is there is no 20th percentile here, which would have been interesting, especially because this agency's 1.87 is so much lower than 4.4. And it would have been interesting to see where that 1.87 would have ended up. Because if I was working with this agency, I would have a concern, doesn't mean that they're wrong in what they're doing, but I would have a concern of the agency discharging prematurely, especially considering the higher average case mix weight. Periods with, oh, well, I wanted to say something else about this too. Okay, and the problem with discharging prematurely, I mean, there's multiple. I would be concerned that if you're discharging prematurely, it's going to have a negative impact on your home health compare scores and your star ratings, which are very important and becoming more and more important as the years go by. And it's going to mean that we are walking away from revenue that we're legally entitled to. If the patient still has a need of skilled services, we should be able to provide those services to the patient. 5th target area, periods with low visits. So this agency had 1.8% of its 30-day payment periods where the total visits either equaled the LUPA threshold or were the LUPA threshold plus 1. And remember, under PDGM, unlike in the past, under PDGM, once you reach the LUPA threshold, you get the full 30-day payment. So this agency has 1.8% of its 30-day payment periods at LUPA threshold or at LUPA threshold plus 1, which is less than 2.4, which is the national 80th percentile rate. Okay, therefore, there's a low concern of the agency just doing enough visits and too many patient encounters to avoid a LUPA situation. But note that that was an issue in 2018 and 2019, because the target area percents in 2018 and 2019 are both red, and they're both greater than the corresponding national 80th percentile for those respective years. Target area number 6, non-LUPA payments. The calendar year 2020 non-LUPA payments for this agency is 68.8% and is well below the national 80th percentile rate of 80%. Therefore, there's a low concern of the agency just doing enough visits to generate a full 30-day payment. But I would be concerned that it would appear 31.2% of all the agency's payment periods for 2020 were LUPAs. Now, I do understand that that was COVID, during the COVID period, but historically, from 2019 going backwards, historically, the national average LUPA rate hovered around 7%. In the 2022 proposed rule, CMS indicated that it appeared that the LUPA rate for 2020 was 8.6%. It went from 7% to 8.6% for 2020. Yet this agency has 31.2% of its 30-day payment periods as LUPAs. Now, this is where you really need to manage LUPA situations carefully, because there's really two types of LUPAs. There's non-controllable LUPAs, and that's where a patient exacerbates during the 30-day period, goes back into an acute care facility, doesn't come out, you can't do any more visits. Nothing you can do about that. The patient relocates out of your service area. Okay, nothing you can do about that. The patient passes away. Okay, there's nothing you can do about that. Those are uncontrollable situations. I would even include in there something that was germane that we generally didn't have much a problem with prior to COVID, but became a bigger issue in COVID, is when the patient is still there in their home, but they are denying the visits. They're saying, nope, we don't want you to come in. Okay, that's still a non-controllable situation. But there are plenty of situations that become LUPAs, but are controllable because maybe we miss a visit and we never make it up for whatever reason. And then that 30-day payment period becomes a LUPA. So the seventh period, the seventh target area is outlier payments. Now, why is this? These outlier payments. Okay, so this agency had 0.9% of its Medicare payments were outliers, and that's well below the 80th percentile rate of 6.2%. And I would even be surprised if it was really that high. Therefore, there's a low concern of the agency overcoding the beneficiary or trying to game the outlier provision. And yes, I have seen agencies try to game the outlier provision for their own financial benefit, which to me is just absolutely ridiculous. Okay, but I have a question though, and this ties back to what I was saying earlier about trying to make how the outlier provision works a little bit less muddy. Okay, and my question is how do you think the outlier provision affects this home health agency? And I would even go as far as to ask a rhetorical question right now. How do you think the outlier provision impacts your agency? Do you have somewhat of a neutral perception of it? Do you have a positive perception of it, or do you have a negative perception of it? Because what I have found when I've gone around all these years talking about this to agencies across the country is that most agencies, at least initially, have a neutral to a positive perception of the outlier provision. And I'll get into that here, okay? Because I want to talk about the impact, the outlier provision versus cash flow, its impact on your agency. This agency received $261,000, over $261,000 in outlier payments during the course of the year. The denominator is $30,251,000. That's the total Medicare payments that they received during the course of the year, inclusive of outlier payments. So what I want to do is I show you what the net impact of this agency is. Because when I initially start talking to agencies, they initially have a positive to maybe a neutral perspective on the outlier provision because they see the outlier payments coming in. What they don't see is the payments that they lose because of the funding mechanism of outliers. So their pre-Medicare outlier, their pre-outlier Medicare payments were 29,990,000, and that's just 30,251,000 minus the 261. The withhold to fund the outliers applicable to this one home health agency, because CMS withholds, they figure out what home health spending is for the year, and they take 5% of it away because of the outlier provision, ostensibly to fund the outliers that are going to be paid during the course of the year. Although half of that actually just disappears and it never comes back to the industry. That's a topic for another day. But the amount of funds withheld from this agency to fund the outlier provisions totaled $1,578,000. Okay, but this agency never sees that happen. What they do see happen is the outlier payments that they received, the 261,000. So this is what generally gives a positive feeling towards the outlier provision. But there's a difference here between what they took from the agency and what they gave back to the agency. There's a difference of over $1.3 million. So this agency would have been better off by over $1.3 million if the outlier provision did not exist. Because if the outlier provision did not exist, therefore there'd be no reason to have this 5% withhold. This agency would have received almost $1.6 million additional, because there'd have been 5% added to each one of their 30-day payment rates over the course of the year, but they would not have received the $261,000 in outlier payments, so they would have been $1.3 million to the good. Something to think about. And I bring this up because it's my recommendation that everybody should take a look at the impact that it has had to their agencies over the years. And this has been going on for years. The eighth and last target area is admission source. This agency has 46.3% of its admissions, red font, okay, coming from institutional settings, because at the 80th percentile nationally, that rate is actually 37.6%. Okay, therefore the 46.3% is highlighted red. So this could potentially lead to issues, although generally speaking, this is one that I would be less concerned about, because it all depends on relationships. And if you happen to have relationships with acute care facilities in your service area, and you get a lion's share of your referrals from them, then of course your institutional admission rate is going to be much higher. So we talked about the first three schedules of the PEPR as being primarily informational, definitional. Then we looked at the 8 that were the target areas. Those are what we just looked at. Then the last 2 are once again informational. And again, these are going to be worksheets in this spreadsheet. We're going to have top clinical groups and the jurisdiction top clinical groups. So I have those on the next slides. So this is top clinical groups for this agency. So we could see over on the left-hand side, clinical groups, and this is those 12 clinical groups that came about because of PDGM, and it's put in a hierarchical manner where we have at the top, we have the clinical group we do the most, and at the bottom, we have the clinical group we do the least. In column number 2, we see the number of 30-day periods we have for each one of those. And then the percent of periods we have for each one of those, total number of visits, not by discipline, but just in the aggregate. And then in the last column, column 5, we have the average number of visits for each clinical group. Okay, this is really good information. It's not real detailed, but it is good information to know, especially if an agency does budgets. Now, I will say about budgets, unfortunately, less than half of the industry does budgets. And I would say 80% of the less than 50% that actually do a budget so inadequately that it provides no benefit to the agency during the budgeted period. And that's what a budget is supposed to do. It's supposed to help you manage your business, your operations during that budgeted period. Okay, But when you do a budget, when you do a good budget for an operation like home health, you want to budget the drivers of revenues and expenses. You don't want to say we're going to increase our revenue by 5% and we have no basis on what it is that why we're going to be doing that. Okay, you want to be basing it based on what is it that drives your revenues? Well, it's your referrals, it's your patients that you get. And not only the patients that you get, where they come from and the type of patients that you get. Okay, so if you're doing budgets, this is really good information to have. So, and this is the same thing for the jurisdiction. So meaning all the home health agencies in that max jurisdiction. Okay, so you could sort of compare what the hierarchy is from your agency to what the jurisdiction's hierarchy is, and also what the average number of visits. You know, why are they higher than us? Why are they lower than us? How are our home health compare scores? How are our star ratings doing? Because if we have very high home health compare scores and star ratings, and we're actually doing fewer visits, you know, and I mean, we could be talking 4/10 of a visit less. You know, I mean, that makes me feel real strong in what we're doing. Okay, but it's all part of learning how to best manage your organization. So that's the PEPR, the Program for Evaluating Payment Patterns Electronic Report. Okay, it provides good clinical operational results that you might not otherwise see, because I don't know of any EMRs that present any of this information in a way that's similar to this. And none of them are going to have the jurisdiction information or the national information like what you see in this report. And it gives the agencies a head up of potential areas of review by the MACs, RACs, UPICs, etc. Remember, TPE audits are coming back. They're not that far away. Okay, and it's free. It doesn't cost anything to get this report. It just takes a little time to pull it down. You know, so in my mind, it's a report that all agencies should download and review every year once it's been updated. So I hope I clarified any questions and uncertainty of how to read and review the PEPR. So I want to thank you for your time. And now we do have a little bit of time left over. So I'll pass it back to Hannah and we'll open it up to any questions that you all might have.
Okay, well, all right, I have some questions that have been submitted. I'll just read them and then John can kind of answer through them. First question, do we have a problem if we have a higher rate of comorbidity adjustments than the 80th percentile nationally?
Well, I wouldn't per se say that you have a problem, but there, like the PEPR report would indicate, it would show that there is the potential for an issue there. But as was shown in the suggested interventions that's at the bottom where the graph is, you just want to look at the medical record. Is it reasonable that you do have those additional, you know, the higher level of comorbidity adjustments? Because the medical record should reflect the patient's condition. And if the medical record reflects the patient's condition, then you should be golden. Because remember, when the MACs, the RACs, the TPE audits are going on, these are all post-payment reviews. They're looking at things in the past. So short of going out and talking to the patient themselves, which isn't always an unimpeachable source, they have to rely on what's in the medical record. And if your medical record supports that, then yes, you know, because if you're just throwing in an ICD-10 code to increase your reimbursement, but it has no impact on how you're caring for the patient, there's nothing in the medical record that supports how that was impacted in how you care for the patient, then you have an issue. But if the medical record documentation, the daily visit notes, etc., are supporting that those ICD-10 codes were valid, then you should be golden.
John, do you consult or perform training on a one-on-one basis for home health agencies?
I'm a consultant, so yes, I do. I mean, if anybody that you want to talk to me, you know, just contact me after this and, you know, we can take it from there. But yes.
You can also indicate that in the survey. and we will get that information to you.
Yeah, because in the survey, I'll get some information and I can follow up with you directly as well. But yes, I do.
John, can you clarify how an individual agency is subject to the 5% outlier provision? Does the agency opted in once there is a qualifying patient?
What was the last part? Does the agency opt in?
Or is it always applied by jurisdiction?
Well, the question was about the outlier, correct?
Yes.
Oh, well, I again, it's okay, because this is where there's a bit of an issue. Is that question, I'm assuming that question doesn't have to do with a reimbursement outlier, to where we get the episodic payment and then we get an additional outlier payment. I'm assuming that it's meaning an outlier in regards to our score, the agency score is over and above the national 80th percentile.
Okay, so I think follow-up question is the outlier percent a standard or does it vary per agency?
No, it's a standard. They use the national 80th percentile to establish what the outlier is. Let me scroll back a few sheets. Okay, because if you look at this, no, let me go back to way back in the beginning. Compare. Okay, because here you see that the agency's rate of low comorbidity means that 44.4% of their 30-day periods had a low comorbidity adjustment. There was just one ICD-10 code that was bringing in additional revenues. Okay. When it was put into the national ranking, that 44% shot them up to the 87th percentile nationally. And anything that's at the 80th percentile nationally or above is what's considered an outlier. So the percent is calculated for the agency. Then they look at where would that agency's rate be nationally, what percentile would they fall into? And if that percentile equal or exceeds the 80th percentile nationally, then it's deemed an outlier. I hope that answered the question. So it's not something you don't opt in, you don't have to do anything. It just happens automatically. It's all just based on the data.
Okay, so just to clarify, the outlier questions related to the outlier payment and the mentioned 5% of non-outlier revenue that was held because there was an outlier payment in the cash flow.
Oh, the outlier, the 5% that's withheld, how this works is, and there's a completely different presentation I have that's on this, but Medicare, CMS sets up this bucket that's home health spending for the upcoming year. Before the year even begins, they reach in and they take 5% out of that bucket and put it into another bucket. And well, they put it into two buckets. And one of those buckets they use to make the outlier payments. So the total amount that was designated as home health spending in the big bucket is actually 95%. And they use that 95% home health spending value to calculate what the 30-day payment rates are going to be based on the HIPS code. So the payment rates that you're receiving for each one of your 30-day payment periods have already been reduced for that 5%. Okay, so that happens at the beginning of the year before any monies are expended or anything. Okay, and then during the course of the year, as you have these higher cost encounters, then you'll get these additional outlier payments. But there is no opting in. This happens for everybody across the board. Okay, and that's why I recommend that everybody take a look at this and see what the impact is to their agency. Because if you went in and you looked at the comments that are submitted each year in the proposed rule, most years, I mean, I've been doing it since '97, since submitting comments to the proposed rule. Don't do it every year, but I do it most years. And ever since PPS has come about, almost every year that I've submitted comments, one of my comments has been to eliminate the outlier provision for home health because it's detrimental to almost all home health agencies. It's just a way for CMS to take away money from the industry. And I say, just put that money back in, give us that 5% back, and let us deal with what we have to deal with until you come up with a better way to devise an outlier provision for home health.
Okay, couple more questions, and then we should be about at time. We have strong ties with a couple of acute care facilities locally that do not have their own home health agencies, so we get a significant portion of our admissions from those facilities. Does our higher rate of institutional admissions put us in harm's way?
Well, it makes you stand out from the norm, okay, from what the national average is. So it's going to, and one of the things I try to talk with my clients or anybody I work with is in this era right now, you want to try to sort of blend into the woodwork, okay, to the extent that you can, not stand out anyway at all. This is going to be one way that when they're looking at institutional admissions, you're going to stand out. But that in and of itself is not a bad thing, because if you can support why you are receiving such a higher proportion of institutional admissions, then no, I would have no problem going toe to toe with the MAC, the RAC, the UPIC, anybody, okay, to support your position. You should have no problem with that. I mean, the UPICs, the RACs, you got to be careful with them because they do have a financial incentive to disallow and to hammer the home health agencies. So you really want to be prepared for that. But as long as your documentation, the rationale why it is occurring is supportable, you should be okay.
Okay, we'll do one last question. Do you have an off-the-cuff example of using the PEPR to help build a proposed budget?
Well, off the cuff, I would say no, because building a budget is kind of a big thing, and we're in September, so everybody should be working on their budgets for 2022 right now, while that's assuming that your calendar year. But in a big picture perspective, okay, we have from a Medicare revenue perspective, well, from any revenue perspective, our revenue in home health is driven by the patient. Okay, so our revenue is going to be contingent on the number and type of patients we get, and not only the number and type of patients we get, but the number and type of patients we get by payer or payer category, if you're big enough to where you group payers together, you know, being Medicare being one, Medicaid being another, and maybe you put all commercial insurance in one, or if the payers are that very diverse, maybe you have 2, 3, 4 different groups of Medicare or commercial insurance payers. But for Medicare, you would take a look at what's the preponderance of payers that we have. Okay, let me scroll that page. We have for the agency, you know, we would take a look at, you know, these top 6 are going to be, you know, 75% of our admissions. Okay, so what's our average revenue for the patients that we get in these different categories? How many patients, how many 30-day payment periods do we expect to get in 2022 in each of these different categories? Or you can group them together, that's okay. And what's the average revenue? And not only what's the average revenue, you really should be looking at what was the revenue that we receive right now in 2021 compared to what's the revenue that we're projected to get in 2022, because since the proposed rule was out, we can identify what our payment rate is by HIPS code. We know what it is for 2021. We know what it's projected to be for 2022, and we'll be able to refine that when the final rule comes out in November.
And John, that's something you can work with agencies on individually as well as a service, correct?
Of course, I would put my budgeting skills up at or above any other financial consultant that you'll find in the industry?
Well, we are at time, so I just want to go over a couple other things. Health Rev Partners would like to offer anyone on this webinar the chance to experience services with no obligation for 60 days. I will place that link in the comments. You just simply type Pepper into the message box. Again, we have 3 Apple AirTags to randomly selected survey participants, so please take a moment to fill out the survey. That helps us plan for the future and find what's helpful for you. Make plans to join us on the next webinar. That's October 21st on PPS. And then we will be emailing a copy of today's presentation in the near future. I hope to get that out this afternoon or tomorrow at the latest. Thank you everyone for participating. I hope you have a great day.